We are the Necrotizing Fasciitis Foundation, also referred to as the NFF. Our mission is to advocate and spread awareness about necrotizing fasciitis, a rapidly spreading bacterial infection that can destroy skin, fat, and tissue-covering muscles, not to mention lives. Often referred to as the flesh-eating disease or flesh-eating bacteria. To contribute, participate, or for more information, please visit our website at www.necfasc.org.
Hello, and welcome everyone to The Steep. I'm your host, Tim Hayden, and on today's episode, we have Dr. Douglas Zatzick, MD. Dr. Zatzick is a board-certified psychiatrist at Harborview and a University of Washington professor of psychiatry and behavioral science. He is also a member of the core research faculty at the Harborview Medical Center Injury Prevention and Research Center. His clinical interests include post-traumatic behavioral and emotional disturbances, traumatic injury, health services, and cross-cultural psychiatry. Remember, if you have questions while viewing this live, please put them in the comments. I will add Dr. Zatzick at this time. Welcome, Dr. Zatzick. How are you?
Thank you so much, Tim, for that introduction. And, you tell me if there are questions already. That's great. I can also just give a bit of general background on post-traumatic stress disorder after, severe medical events, trauma, like necrotizing fasciitis, whatever you prefer.
Please go right ahead. Tell us about PTSD and the different types of PTSD.
Sure. Well, PTSD, post-traumatic stress disorder, is a psychiatric syndrome brought on by an exposure to an overwhelming traumatic life event. And, that event can be a motor vehicle crash. It can be getting shot at. It can also be a medical event, a sudden cardiac arrest, or necrotizing fasciitis. Say, you have a bacterial infection, you have to go to the intensive care unit, you have necrotizing tissue, you have to get an amputation. All of that would constitute an event that threatens life or limb, and so in the wake of that overwhelming threat, there are a few sort of symptom clusters, types of internal experiences that develop that sort of comprise PTSD. The first kind of symptom is an intrusive symptom. That would be like a memory that you don't want to happen, but say you're in an ICU for a couple weeks, and you go outside and you're at your house and you smell something like alcohol or something that reminds you of your hospital experience, and all of a sudden, as much as you're trying to forget that experience, you're back in it, okay? And and you can really be back in it, totally absorbed by it, and that's called a flashback, like where you forget where you really are and you're just back in that intensive care unit, okay? The intrusive symptoms can also come not just during the day while people are awake and conscious, but at night, in terms of sort of intrusive nightmares that wake you up from sleep. ICU nightmares can be even things just like almost like black hole experiences where it's blackness and you have a general sense of anxiety and it sort of beckons you back to the intensive care unit, but there may not be content related to the dream. It may not be specific content about something that was happening in the ICU, okay? And even as I describe this, hopefully I'm not, people may have had these experiences. My intent is not to have, stimulate the experiences, but to talk about them. And then later on in this discussion, we'll talk about what you can do, okay? But so, what are the treatments for PTSD? So those are intrusive experiences. That's sort of what we call the first symptom cluster or type of symptom, okay? The next type of symptom for PTSD is avoidance symptoms, like, gosh, I was in the ICU for 2 weeks. I don't even want to go back to the hospital. I come near that place and I get the heebie-jeebies, and I'm not going to my appointment. I know I need to go to my appointment. I know, but I'm not going. It freaks me out too much. I'm too anxious. My heart races. That's an avoidant experience, okay? Or, what's an example? Like how can you get necrotizing fasciitis? You can go for a lake swim and the bacteria, and you just realize you've connected in your mind that that's where the infection happened, and you never want to go back to that lake. Okay, that would be an example of avoidance symptoms. Okay, avoidant symptoms can also be things like emotional numbing. Okay, and sort of that sort of thing. Just sort of not feeling like you're close to anybody, feeling isolated socially. Okay, the next symptom cluster is something called arousal symptoms, signs of autonomic or psychophysiologic arousal. And those would be like, say you're in the ICU and you had a IV drip, and there's a sound, like there's a beeping sound when it's empty, and you're sitting at home and you're in your living room, and all of a sudden there's a truck backing up, and it's got a similar sort of beat and cadence and pitch to the ICU IV drip beeping when it's out. Boom. That's it gets a flashback going, but you may just startle, right? You may just like, oh my God, what is that? So hyperarousal, startle, irritability, anger, that's part of PTSD. Okay. There's this idea that you could take sort of in the new formulations of PTSD, it's risk behaviors, that you take risks, that sort of thing. That you're sort of it's part of the arousal symptom cluster. And finally, there are emotional symptoms, things like shame and guilt and angst, negative emotions that are also part of PTSD, and certainly sadness over loss, loss of a limb, whatever the physical sequelae are of your necrotizing fasciitis or other injury. So that's the syndrome of PTSD. Okay. Now, Tim, I could go into sort of thinking about treatments and like appropriate, like how do you deal with these symptoms? Okay. So normally for most people, and a lot depends on the severity of your losses, of your physical injury. For most people, okay, you generally, everybody has some symptoms, like you might not be able to sleep or you might have arousal symptoms, but for the most part, things gradually improve. Okay. If you have scars on your face, or you've lost a limb or a hand and there's stigmata, that could make things worse. Okay. But there are things that, or if you had a really long, prolonged medical stay, like a month in an ICU, that could make things worse. But for the most part, people are going to gradually recover. Okay. But there are telltale signs, like, what you want to do is you want to just, the first step in most everything is sort of developing self-awareness. And the first step is just being kind of knowing who you were before your trauma exposure, and then thinking about who you are now and what are the signs that I'm a little bit on edge. Okay. Like, some people may have a tendency towards working on a computer, and then all of a sudden that's all they do, and they're isolating themselves. Other people might have a tendency towards a couple drinks a night, and now you're drinking a 6-pack every night, and you started drinking in the morning. Other people, used to go out and go around the community a bunch, and now they don't want to do that. They don't want to interact with friends. Like, these major changes in behavior are sort of things to watch for, and you can often get feedback from friends and relatives as well. And the problem with a major medical illness like necrotizing fasciitis is that your mobility may be different. So along with the behavior change, there's a physical impairment for you. Okay. So, for the most part, there are a lot of sort of, if you've got positive coping, like maybe you had an exercise practice that isn't too hampered by your new physical, mobility issues, or that you can get back to in part, that you can work with a PT or, your orthopedist or whoever to sort of get back into your exercise regime. Like, that could be curative. Getting back and active and feeling like you can, if it's May and it's really nice weather out and you were going to go fishing and you're avoiding lakes, but you can not splash water on yourself, and there are things you can work it through with. Even it doesn't have to be a psychologist; it could be a physical therapist, or somebody else, a group of supportive friends. You can work to get back to activities and overcome avoidance, and naturalistically. You don't have to always have it. Or maybe you used to go to church group, or you used to have some sort of reflective practice that wasn't psychotherapy. Whatever it is, you're trying to get back to your normal regime. I mean, it goes without saying, like eating, sleeping, like you used to eat 3 meals a day. You're trying to get back to that. I used to sleep 7 hours a night. You're trying to get back to that. I used to hang out with my friends. You're trying to get back to your normative routine. Now that may change because of your new physical limitations. Totally understandable. At the point where you're realizing, gosh, it's been weeks or months and I'm still, that garbage truck backs up and I'm still off the couch and I hit the ceiling and my pulse rate's up and I'm in the middle of a flashback and I have startled, and whew, that might be a point where you say, God, maybe I need to do more. Okay. Psychotherapy, so session-based discussions of the event, what happened afterwards, where you are now, sort of thinking about your trauma narrative, focusing in on the anxiety. There are therapies that are shown to be quite effective for PTSD. Okay, assuming that it's a single incident and it's not like the umpteenth trauma in your life. I mean, that makes it more complicated. But say you did go for that lake swim, and say you came out with necrotizing fasciitis, and say you were in the ICU for a week, and say even you've had an amputation. A course of 12 or 16 sessions may be really helpful with a therapist who's been trained. Okay, with not only are there psychotherapies, but there are medications. If you've got an amputation and you have some sort of peripheral neuropathy, there are antidepressants that also treat pain. There's a medication, duloxetine, Cymbalta, that at sort of normative doses can help both with PTSD symptoms and pain from peripheral neuropathy. So, and you can do both. And the key is that there are ways to approach this, and they don't have to be stigmatizing. They're part of, people usually now in medicine understand that this is something that happens. And more, I think, in the community after 9/11 and the Iraq and Afghan wars and all the problems we've had in the US with civil unrest and violence and injuries, I think people understand that trauma, or Ukraine or Afghanistan, that trauma is serious stuff and can require sort of specialized treatment. I think there's an acceptance of that. Okay. So, those are general comments, Tim. I don't know if you have other questions that either folks who are listening have, or, maybe we could spend some time sort of, weaving in comments others have or comments you have.
All right. One that I've got is best way to control panic attacks from your PTSD.
Yeah. So panic. So there are two, like PTSD can be something that just, you feel anxious all the time and your heart rate is up and you're just exhausted by the symptoms. There's also, it can also be sort of episodic. Paroxysmal is a medical word, like boom, it's on you and it's not. Okay. There are different ways to deal with that. I mean, a lot of the cognitive behavioral therapies, the CBT, cognitive behavioral therapy, start with trainings like breathing retraining, muscle relaxation, so that when the cues, often panic attacks or sort of traumatic triggers, we usually think of them like say, let's take the instance of a truck backing up and making the same sound as you hear in the ICU. If you train yourself with a therapist, or there are tapes you can get there's all sorts of stuff you can do before going to therapy. You can try and train yourself to sort of do gradual deep breathing when you hear that noise, if it's predictable, and you can take a big inhalation and exhale, 1, 2, 3, 4, 5. If you can work to retrain yourself, that's a huge win. Okay, I think that's so much better than taking a medication. You can take medications also. There are medications that will help you quell that will help, that will help your nervous system calm down. But breathing retraining, gradual muscle relaxation, if you can train yourself when the cues come up that incite the anxiety or the panic, that's a real win, because then you also get a sense of mastery over this, what seems like it's just outside of you. All of a sudden I'm overcome by this anxiety, but really there are ways to physiologically retrain yourself. Okay. There are medications also, and the worst of the medications, I'll just start with those, are the benzodiazepines, things like Xanax. They might give you temporary relief, but you're going to need another dose of Xanax or Valium or Ativan. And so there are medications that the serotonin-specific selective reuptake inhibitors, that class of medications, if you take those for 4 to 6 weeks, that can definitely reduce panic attacks and anxiety and PTSD. Those are things like sertraline or Zoloft is the brand name, fluoxetine or Prozac, paroxetine or Paxil, citalopram or Celexa. Those are all really good medications for post-traumatic stress. And like we were talking about, there are other medications that help with pain and anxiety. So duloxetine or Cymbalta, venlafaxine or Effexor, those can also be helpful. Those are prescription medications, so you need to, your family doc can prescribe them if you're lucky enough to be able to find a psychiatrist. It's hard to find psychiatric referrals these days. A psychiatrist is also able to prescribe those. There are medications you can take more on a dime when you're having the panic attack. You shouldn't operate heavy machinery or do other dangerous things, but medications like trazodone or prazosin, those can help at night for sleep. They're not habit forming, okay, but they can help with going to sleep and sleeping. Like if you have nightmares, those medications can be helpful. And there are other more tranquilizing medications that have been shown to be helpful for really overwhelming panic. Okay.
Well, I myself, as a necrotizing fasciitis survivor, and I know a lot of other survivors suffer through this and were at a loss as far as trying to pinpoint what causes this, but most of us suffer from memory loss. Can the PTSD cause that as well?
Yeah, so say you're in an ICU for a while, and that memory, being unable to remember things, is a very common symptom. Okay, there is something called a traumatic amnesia, where something is so overwhelmingly traumatic. Say, I don't know, with a slower bacterial infection, it may be the moment that when you realize your blood pressure is dropping or something because you've had this infection and you're septic. Like, there may that episode or moment you may panic, and have uh, sort of have memory loss for that moment. Okay, the ICU in and of itself can be a place where you lose memories. Okay, and but the trauma in and of itself without the medical illness can cause amnesia. Yeah, but it's sort of, we say, confounded. It's mixed with other stuff. Yeah, so.
What can a person do to help someone else who's suffering with PTSD?
Well, I think like I was sort of alluding to, Tim, that there's sort of a place where people they've been to the hospital and they're coming out and they're going to have a natural sort of, their symptoms are going to go down. Their sleep might get better normatively, like 70-80% of people. Okay. Now, like I said, there are things beyond our control. Like if you used to have a right hand, you don't have a right hand, and you're looking at yourself and you're going to go out to work and everybody sees you're not going to have a right, that's a traumatic reminder, and you can't do that's going to make that. Maybe it's 40 to 60%. We've done a study with 3,000 people. Hand and facial injuries make PTSD worse. Facial injuries, you have to wake up every day and look at yourself, and that's a traumatic reminder. But normatively, in your usual sort of circumstances, things, you can gradually heal from this. Okay, and having good social support, people who aren't insisting you do X, Y, or Z. A good, I don't know if you do much with peer programs, Tim, but like, a good
Yes.
peer listens. They might say, gosh, you're talking about how hard it was to climb stairs or is, and boy, I went through that for 3 months. I had that same experience. They're not like, oh, you should build a ramp right now. And, it's more like you're listening supportively, somebody who can be a supportive listener without a lot of shoulds and to-dos, but can really sort of just empathize and listen, that can be really helpful. That can really help someone who's on a course for natural recovery. That can help that course of natural recovery. Someone needs to tell their story, needs to talk about the new things that are really uncomfortable or challenging in their life without a lot of prescription, and then at the point where, gosh, we've been talking about this. We check in once a week, and gosh, I don't know what to do, but it seems like things are still really pretty bad for you. Here we are 3 months out. What do you think? Have you talked to, you have a family doc, you go in monthly to have your prosthesis looked at. Why don't you mention it to the doc? Just see what they say. Rather than saying, "Oh, I've got a great therapist." You don't want to make the diagnosis, but you can listen and sort of suggest that the person connect with whatever medical provider they have and see what they can do, right?
I do know you were talking about a place to talk. We have probably the largest support group on Facebook for necrotizing fasciitis survivors and loved ones and bereaved. And one of the most common comments we get from new members is that they're glad they found this place because they can talk to people who will listen. Their families have stopped listening to them. They're like, just get over it. So we provided a safe place that we really monitor to keep outsiders out if we can. Here's a submission. How can someone, especially a young person, deal with PTSD-related separation anxiety? For context, my son was 4 when he had NF and remembers waking up in the hospital and not seeing us there. He just didn't see us apparently. Once he was discharged from the hospital, he developed severe separation anxiety to the point that he would cry if she went into the other room. Even now, 4 years later, he gets anxious if I run out to the car or run into the gas station really quickly and he's left with just his older sister. He did therapy, but it was during the pandemic when we were all quarantined together. I'm not sure how much it really helped. And I do know that he is a survivor. He is an amputated survivor who she's talking about, her son.
I think so. The pandemic. Talk about throwing hopefully we're who knows. Another therapy before the pandemic. Therapy in kids, and there are different phases. There's 0 to 5. So he's had this episode at 4. We've done some child work here at Harborview. I've worked with pediatricians, and so we're really interested in medical illness in kiddos. I'm not an expert on this, but basically under 5 is one group, and then treating a kiddo who's in latency, school age, 5 to 12. There's some pretty good treatments for anxiety during that period. Now, with an amputation, it may take more, and with the pandemic, it may take more than just one course. So if you like the therapist, if you feel you've done good work, it might be worth going back and seeing if you can't sort of re-engage again, and it may be sort of a phased or stepwise way to go. Set of therapies. There are also medications, but for younger kiddos, I think there's an evolving literature that medications can help with anxiety and separation. But I always like to try therapy first, and if your child has tolerated a course of therapy, I think it's always better. Again, this sort of sense of self-efficacy is so important, and it really is something people get out of therapy, and you don't get that from taking a pill. So
Right. I agree. A couple more. When NF affects your career and causes you to lose or be unable to work, what is the best way of coping with all of this?
Those are great questions. And, they're just like they're psychotherapists, they're occupational therapists. Sometimes after an injury, you can retrain to do something if you've lost a limb and that was an essential part of your job. There are retrain if you want to be gainfully employed, which I think is a fantastic. You can work with an occupational therapist. I think a lot depends on the context of your injury, and
Here's what someone just submitted. I haven't been able to leave my husband in 6 years now. Is that normal? Separation anxiety and I were super independent before.
Yeah, I mean, it sounds like there. I mean, I always want to know more. I mean, are there things you're dependent after? I don't know what happened 6 years ago, but are there things you're actually dependent on your husband for, like mobility or help or lifting? That would be a reason. But if it's purely emotional, or there's a major emotional component, that could be something to take a look at. And how you do that, I mean, I think it's great that you've got a support group. You could initially sort of throw questions out to the support group, and get peer sort of answers and support, because a peer might say, well, God, that happened to me. It happened to me for 2 years, and then I did this and this, and you could get ideas. But then also, if you come to consensus with your family and your peer group that there's more work to be done, certainly engaging a therapist may be a good thing. So.
Here's one more. How do you find value after sickness when you're able to monetize your value before?
That's a great question. And, I do research, and we have health economists, and we're trying to figure all this out and return to work and post injury. But at an individual level, I think it's really challenging. I mean, I think it's hard. It's a really hard thing. It's, certain things one loses from medical illness, and certain things one experiences with PTSD are sort of priceless. You can just, and so often, I can't, you can't help but think of some of the images coming back from Ukraine. Woof, and I'm just saying, like, those are very difficult questions, and PTSD has a lot of different contexts. So it's very hard for us to do. And certainly, we have health economists we work with who are days of work loss, work days, that sort of thing. It can be done, but I'm just careful about doing it. So, yeah.
Well, Dr. Zatzick, thank you for being here
You're
and helping us
welcome.
with all this information today.
Yeah.
If you have more questions for Dr. Zatzick, please send to the info@thesteep.org, and we will get them to him and try to get some answers. Thank you so much for being here, sir.
You're welcome. You're welcome.
You have a great day.
You too. Take care.
I hope to see you next time for another episode of The Steep. Please remember to subscribe to our YouTube channel. And as always, remember to be kind and smile.